So thank you very much, the organizers and the Takeda Group, for this kind invitation to give my this presentation about my personal experience and my approach to how do I treat patients with primary immune deficiency. I'll start with just my laser. So these are my disclosures as per requirement. And this is the outline of my lecture for today. I will give you a very short overview over primary immune deficiencies, PID, how to evaluate, diagnose, some treatment considerations, and I will be finishing with trying to convince you why you should use primary immune deficiencies or antibody deficiencies subcutaneous treatment. Well, to start with about primary immune deficiencies, that would be easy if we would be still writing 1971, because at that time we knew about 12 immune deficiencies, and that would have been easy to describe today for me. However, the latest literature, the 2019 update from this society, which contains all the immune deficiencies that are described up to today. They are presenting for more than 430 diseases. This is the slide showing the number of immunodeficiencies that have developed or have been discovered during the last year. And since this update in 2019, there came out one more interim report adding another 50 of these diseases. So as you can understand, it will be kind of hard for me to give you an overview of all these 400 plus diseases. So my talk today will be, this is in this list, this is the 10 groups in all these, where all these 400 plus diseases are grouped. And for the scope of this talk, I will be keeping myself to this group, which is the antibody deficiencies, because they are the ones which are treated with subcutaneous or intravenous immunoglobulins, and that's easiest to put together in one group. The reason also why I'm talking to this, because for us in Europe, this diagnosis is the most prevalent, as you can see in this picture from the EC, the European Society of Immune Deficiency Registry. More than half of our patients are predominantly antibody disorders. I'm just going to touch upon evaluation and diagnosis, and you have to ask yourself two main questions: when to suspect it and how you can test it. Maybe some of you are familiar. If not, I'm warmly recommending these publications and these websites. This is the most famous one from the Jeffrey Model Foundation, where you can have a list, where you can download this list of those so-called warning signs for that should alert you for the presence of immune deficiency. It doesn't necessarily mean that these if a patient has one of these signs, that the patient absolutely will have immune deficiency, but it's just a sign that it could have been. And these are very useful. However, there have been some publications showing that these 10 warning signs are not useful as a screen for immune deficiencies, because they do not include, in the last 10 years publications, we see that there are lots of immune deficiencies that do not go with just infections, which is the main focus on these warning signs, but we do see that primary immune deficiencies contain now diseases with autoimmunity, autoinflammation, malignancy, and also the infections. They don't have to be constant, they can be also sporadic. And also, if you try to apply, there was this nice publication from the group in England showing that in their cohort of patients, about 1/3 were identified if they looked at only the warning signs. And considering this, here comes my first personal touch, which is maybe not that much personal, but more for our region, for the Scandinavian. We have made new warning signs, and this is our warning signs. We still keep them at number 10, but we did add to these ones these new diseases, and we are on our way to do an evaluation how well these ones would perform in a cohort of immune deficient patients. These are available for anybody who wants to see on our website. We have made the same for adults, and I'm more familiar with the pediatric ones. So how to suspect it? Use the warning signs. They will help you to find the patient who has immune deficiency. Next step would be, how should you test? And when I'm trying to tell my colleagues or the students how should they test, I'm trying to tell them to think about 4 pillars of the immune deficiency. If you have correct numbers of cells, if they are functioning as they should be, you should look for antibody deficiencies, you should look for phagocyte disorders, and you should look for complement deficiency. I mean, in these 4 groups, most of the immune deficiencies that you will be finding will be included. I usually give them a list of tests. Some of them are basic, a normal CBC, every lab can do it. There are some more specific tests, and here I just want to make you, since I'm a pediatrician, I want to make you aware that you have to be compared to age match controls. So a child has different values compared to an adult in many of these parameters. So don't forget to look at the age matched values. And another caveat I'd like to say is that patients with secondary immune deficiency, and that's HIV, the most common worldwide, will be also in your cohort. What will you find? What that you will find, and therefore don't forget to test also for HIV. There are lots of protocols out there published about how you should go forward, with what stages, when should you take these tests. And there is, again, on the Jeffrey Model Foundation webpage, the staging in 4 stages, how you should do it. It's freely available to download if you're interested. And I'm giving you again our Scandinavian approach to it, because we are considering it also stepwise, but more looking at from the practical point of view. Who can do? A general pediatrician or a general practitioner, anybody can do a complete blood count and measuring IgG, ANM at all labs. Most labs will be able also to measure these specific antibody productions. Then you'll have the more specialized immunology labs for measuring complement and lymphocytes. And then you will have these more advanced tests where you need more specialized labs. But if you are looking for your immune deficient patient, as I see, most of us would be able to at least to this level to test for immune deficiency. Going further to treatment considerations, and be aware that I'm not going to talk about all these 430 diseases, but I'm going to talk about the antibody deficiencies. And the treatment for antibody deficiencies is immunoglobulins. And just a short repetition, what is immunoglobulin? You have to be aware that every batch that you are giving to a patient is made from a plasma for more than 1,000 donors. So you're giving them a very broad repertoire of IgG molecules. And it's used as a replacement therapy. So it's not going to treat your patient's deficiency. It's just going to replace what is missing, and you have to replace it continuously. The content is more than 95% of it, it's IgG. So remember, you cannot give this one to a patient who has IgA deficiency only, because this doesn't contain IgA, it contains IgG. or there are minute amounts of IgA, but that's not really relevant in most of the cases. They are all very safe, and it's important to remember that immunoglobulin will protect your patients against a broad range of infections. The question which I'm always getting is, to whom shall I give, Nicholas? To whom shall I give these immunoglobulins? Well, there are a group of diseases where they must have immunoglobulin treatment, and that's the X-linked amyoglobulinemia, the XLA, the hyper IgM syndromes, severe combined immune deficiency, Wiskott-Aldrich syndromes. So if you find the patient with this diagnosis, then you start your treatment. And then there is another group which is a little bit more tricky, because first is that they have to have an antibody production disorder, and usually it's required to have infections in order to give the immunoglobulin. And I'm talking now only about primary immune deficiency, not about secondary and not autoimmune diseases and so on. So I'm talking about primary immune deficiencies. So two groups, either genetic or you have the antibody production disorder and infections. Today, we have two options to treat patients with immunoglobulins, either with IVIG, like intravenous immunoglobulins, or subcutaneous immunoglobulins. And what's the difference? Well, the main difference is in pharmacokinetics, because if you give the patient IVIG, you will have the same day a very high level of IgG in the blood, and that will slowly decrease until the next injection, and you will have this curve of high tops and then slowly receding levels. Immunoglobulin subcutaneously will give you a more equal level in the blood. The variation will be not so high. I will come back to this part of the treatment a little bit later. How about what dosage you should give? The internationally most of the centers would be giving your patient 0.4 to 0.6 gram of immunoglobulins per kilo body weight every 4 weeks. That's the standard treatment. Obviously, you can do every 3 weeks and then you calculate the dose. The subcutaneous treatment, usually the same monthly dose, but you will divide it at weekly intervals. And even there are patients who are receiving 2 or even 3 times a week, but the monthly dose will be the same as with IVIG. I'm just showing this graph so you have an understanding about the levels. This is trying to show the level of IgG just before the next injection, so the trough IgG level in relation to how much you are giving. This was measured for the IVIG. These dots and squares are different studies where they looked at it, and the size of them is dependent on the size of cohort where they looked at it. And as you can see, there's a pretty straight line showing that the more you give, basically, the higher trough level you will get. So that's a principle to remember. And why is this important? Well, because in this very nice study has shown that the higher, as you can see on this line here, the higher trough level you'll have, the lower will be your patient's risk to have infections of pneumonia. And basically what they are saying, that for every 100 milligram per deciliter, that would be 1 gram per liter for those who are used with more that measures. So every increase of 1 gram per liter or 100 milligram per deciliter will decrease pneumonia risk by 27%. And that's very relevant when you're treating a patient who is still having infections. The big question is, however, should you choose SCIG or should you choose IVIG? And I'm just going to give you some pros and cons for both treatments. Well, if you have the IVIG, you will need to have treatment every 3 to 4 weeks, while the subcutaneous is weekly treatment usually. Infusion time much longer for IVIG. For IVIG, you need venous access, which for me as a pediatrician, it's a tricky question because kids usually hate needles, while the subcutaneous treatment usually goes much easier it's easier to administer. The adverse events, I'm going to come back to it in a moment. Home therapy is not possible usually with IVIG, at least not in Scandinavia. We do not have nurses traveling home to the patients, and usually there are very few patients who are able to insert their needles. So we usually do not recommend IVIG on home treatment. It also requires trained personnel, while if you have a subcutaneous treatment, then usually the patient can do it or the parents can do it themselves. As I showed you in this first graph, there is a large shift of IgG levels that happens. You will have very high levels the first day of the treatment, and then it will slowly go down, while with subcutaneous treatment, you have a more consistent IgG levels. However, with subcutaneous treatment, you might need pumps, which can be problematic in certain parts, certain countries. And the IVIG can be given to bleeding disorders. Actually, this is now it's on our way to be shown that it's possible to give even subcutaneous if you have bleeding disorders. So I will have to update this slide, I just realized. And the subcutaneous treatment fits very well patients who are living far away from the hospitals, or they have a busy schedule. They don't want to waste daytime to sit in the hospital to get their treatment. And it's by that increases the autonomy, and it's also cheaper, and I'm going to come back to it. On the adverse effect sides, they're a little bit different. IVIG, there have been some reports showing anaphylaxis or anaphylactoid reaction, while on subcutaneous treatment, you will have local swelling, itching, and erythema. And there are some common ones which appear, which are independent on the route. Some patients will experience this, especially in the beginning of a treatment. And experience, here comes my next personal touch, is very clear that not just for me, but for all of us working with this type of patients, that if you have a side effect, usually lowering the infusion rate will get you less side effects. So lower the infusion rate. And also when you come to the infusion site reactions for the subcutaneous treatment, we have a very nice study published from Sweden. And what is this one showing? The percent of adults that will react when they start their treatment on subcutaneous immunoglobulin. And what's interesting with this slide is that, as you can see, after about 6 to 8 weeks, the percent of patients reacting will decrease. And also, it's very important what the message from this one was that those patients who will stop reacting, they are in the group of who are not switching the injection sites. So in contrary to what you would instinctively say to your patient, oh, if you reacted on one side, next time put the injection on the other side. No, keep the injection on the same side, because the skin will kind of get used to it. And this is visible on all the parameters. They looked at it: redness, swelling, local heat, local pain. The red dots is at the beginning of the treatment, and the blue ones at the end of or after 6 months. As you can see, the side reactions are going down. So keep giving it to your patient on the same site, and your patient will have less symptoms. And now, in the end of my talk, I will try to give you 10 good reasons why you should be using subcutaneous immunoglobulins. Well, first of all, because it has been around a long time. We were here in Sweden, the first one who published in Lancet more than 30 years ago about the possibility to give subcutaneous treatment. So this is one of the reasons it has been around a long time. The second reason is that when they started looking at it, and this is the first publication which was made on two different cohorts, one in Sweden and one in the UK, what they could see that it was actually comparable to IVIG, which at that time in the 90s or 80s, it was the standard treatment. So the subcutaneous treatment would give you the same protection against infections. And after this publication came out many more publications, and this is just a summary of a meta-analysis of these two treatments. Lots of publications, lots of patients, and the most important take home from this one is that the subcutaneous treatment was comparable or better than IVIG treatment regarding lots of parameters, both the trough levels, the infections rate, adverse effects, patient's preference. So on most of these parameters, the subcutaneous treatment is better. So even a meta-analysis showed this. Also, the switching, if you have a patient on IVIG, it will benefit the patient to switch to subcutaneous treatment because the trough level will be higher. And as you remember, the higher trough level means less risk for infections. And how should you do the switching? Actually, there is no clear line on that one because in Europe, we are saying that we switch directly. So we use the same monthly dose of IVIG compared when we switch to the subcutaneous dose. So if the patient had 100 milligram per kilo body weight per week, then they will have the same dosage in subcutaneous also. However, in the US, they suggest that the milligram IgG the patient are receiving should be increased. And the jury is still out there, which of us is correct. I'm coming from Europe, from Scandinavia. We are absolutely convinced and it's working. So in my personal experience is also, we can keep the same dosage as was started with IVIG. Also important to remember that subcutaneous treatment is more feasible for patients who reacted to it, and this nice reacted to the IVIG treatment. This very nice study from a colleague of ours in Italy has shown that in this big cohort, they had 13 patients who had anaphylactic reactions or very severe reactions to IVIG, and when they switched them to subcutaneous treatment, 11 of them could do it without any reaction, and the other 2 were still having some reaction to it, but they could still continue the treatment. Without the subcutaneous, they would have not been able to receive any immunoglobulins. So if you have a patient who's reacting to IVIG, it is also a very good option to switch to. It has a much better safety aspect, as I have shown to you. The systemic, this part is the intramuscular. It's not really actual. Not too many countries they are using it. So just look at the lilac and the purple and the green. The adverse events, it's a huge difference. So usually, if you have a reaction, it will happen on the IVIG and not on the subcutaneous treatment. Another reason is that actually the patients prefer it. In this study, which was published about 10 years ago, they looked at the needs and how does it look in patients. And this was a study done in lots of countries, 21 countries, and they interviewed a huge amount of patients all over the world. And what they found is this complicated picture, and it's not the point to read everything. It's just to have a visual view. The more to the right you are with something, the better it is. And as you can see, in all parameters that they looked at, the blue is the subcutaneous treatment and the orange is the intravenous. In most of the parameters, the blue, meaning that the subcutaneous outperforms the intravenous. So it's better. And also in this study, They looked how the patients would prefer it, and just to conclude that they are saying that all patients desire for as few infusions as possible, which is unfortunately not the case for the subcutaneous, but all the rest to administer at home, self-administration, shorter duration, and fewer needle sticks, it's by subcutaneous treatment is fulfilled. Also looking at quality of life, for those of you who are interested in this type of parameters, it was very clearly shown that if you start a treatment for switching from IV to subcutaneous will improve in the patients both the general health perceptions, vitality, and body pain. So it will benefit your patients, they will feel better, and there are several other studies showing the same for children. Last but not least, economics. It is cheaper to give subcutaneous treatment. This is just a table summarizing how much would it cost you if you give the IVIG in the hospital. This is compared in different countries and compared to subcutaneous at home. As you can see, you can make lots of savings for your healthcare if you do the treatment at home instead of at hospital. And then the last reason why you should do it, because everybody else is switching. As you can see, 15 years ago, this is the European database. 15 years ago, we had over 80% of our patients on IVIG. Now it's down to under 50%, while the subcutaneous treatment is increasing. However, in the end, you have to also not to forget this, that we have in our hand all the heads, the medical indications, the comorbidities, venous access, the cost, if this patient suitable for the home therapy. However, don't forget that the patient has totally different goals in his mind. How can they travel? How will it affect leisure and activities, work? How about family? So in my opinion, that the most important thing is that you have to actively involve your patients in the process of choosing the treatment option. And finally, as I said, I'm coming from Sweden. This is Sweden in Europe, and this is the part which I'm in charge of. I'm in one of the three major centers, national centers that are complete considering pediatric patients. And do I do as I preach? Well, this is my cohort of actual patients. All these letters, they are the different immune deficiencies. The biggest group, as you can see up to here, it's the antibody deficiencies. So it's not as much as in the database, but that's because children are having a little bit different profile. But anyway, I have lots of patients with different diagnoses, and these are all those patients that have antibody deficiencies and are treated. And these are the diagnoses for those antibody patients, antibody deficient patients, XLA, common variable immune deficiency, subcutaneous, after SCID transplantation, specific antibody deficiencies, and hypogammas that do not fit in any of these characteristics. And this is how it looks when I treat my children. I have the green ones are the subcutaneous treatment with the conventional either 16% or the latest, the 20%. And in Sweden, we do have also the facilitated subcutaneous immunoglobulin, which is not part of my talk now, but as anyway, the sum of these ones is that I have over 90% of my patients are on subcutaneous treatment. And the same is true for my colleagues, for example, in Stockholm, because looking at them, they also have just 1% of their patients on IV treatment. They are having some older patients who refuse to do anything else than the intramuscular, something that we are never using on children or any newer patients, but some patients, and we are all aware that some patients are very want to stick to their old treatment, so they have this 3%, but 1% IVIG, and the rest, over 95% is subcutaneous treatment. So we in Sweden and in Scandinavia, we are very much in agreement with each other that we are using subcutaneous treatment. So that would be my talk, and I'm happy to take questions.